So welcome everybody today. We're delighted to have you on this webinar where we will be focusing on the importance of quality spirometry services and FeNo testing in diagnosing and monitoring respiratory conditions. This webinar is being delivered by Education for Health in collaboration with the Task Force for Lung Health, and this webinar is sponsored by NewMed Healthcare. My name is Preeti Minhas and I'm the Assistant Director of Clinical Learning at Education for Health, and I'll be your host today, and I'm supported by a team of our speakers today, which I'd like to introduce. So Fiona, next slide please. So Julie Lennon, who is one of our clinical associates at Education for Health, Dr. Steve Holmes, our co-chair of the Task Force for Lung Health Diagnosis Working Group. Next slide, please. Rachel Warren, Diagnosis Policy Lead for Task Force for Lung Health, and Pablo John, Senior Policy and Projects Manager, Task Force for Lung Health. Next slide, please. So today, what we'll be focusing on. So as a first, we'll be looking at what is quality assured spirometry. Why is quality assured spirometry important? We'll be looking at recommencing spirometry services. What is FeNo and delivering FeNo services? And just to make a note for today, our sponsors have not influenced the content of this webinar today. So as we progress through today's content, if you do have any questions that you would like to put to our guest speakers, if you can put them in the chat, and as we progress towards the end of the webinar, we'll take those questions. So the chat function is located at the top of your screen, and if you click that, you will be able to put your message in there or your question in there, ready for our speakers. So without further ado, I'd like to introduce our first guest speaker, Julie Lennon, for today.
Thank you very much, Preeti, and thank you for the introductions and the opportunity to talk to you today about what is quality assured spirometry and why it is important. Next slide, please. I will take you through what is quality assured spirometry and why it is important. The ARTP provides this statement: spirometry performed by people who have been appropriately assessed as competent, demonstrating that they have achieved the standards established by the ARTP for the performance and reporting of spirometry measurements. And there are several documents that provide guidance, recommendations, and a minimum standard of spirometry provision to assure the delivery of quality assured spirometry. So you can see the focus is on demonstrating that those performing or reporting, originally referred to as interpreting, have been appropriately assessed as competent. Next slide, please. To improve the quality of both performing and reporting spirometry, a guide to quality assured spirometry, formerly known as the QUADS document, was published in 2013. Several other publications have followed, all of which guide the performing and reporting of spirometry in all healthcare settings. They serve as a reference for all healthcare workers to reinforce the importance of delivering a quality assured spirometry service to our patients. And the recent publication of the ARTP Standard Operating Procedure, known as the SOP, which was published in February this year, covers a standard procedure for which can be utilised in all healthcare settings where spirometry is performed. It's intended as a basic guideline which you can adapt alongside your local protocols. And the ARTP Spirometry Certification Standards document, updated last month, describes the standards set by the ARTP as the provider of spirometry certification, and it sets out what to expect from a spirometry training provider, such as Education for Health. Next slide, please. So following the publication of the NHS Long-Term Plan in January 2019, NHS England and NHS Improvement produced their spirometry commissioning guidance. The document confirms spirometry testing is variable in terms of quality and accurate recording on patients' records. They confirmed there are challenges in having enough trained healthcare professionals who can perform and report spirometry tests, both in primary and secondary care settings. The ARTP Spirometry Certification Standards document, updated last month, confirmed in order to successfully achieve ARTP certification in spirometry, healthcare professionals should undertake a period of theoretical and practical skills training with a suitably qualified training provider, such as Education for Health. Education for Health works closely with the ARTP and provides a variety of interactive, blended online spirometry courses, including ARTP assessment access courses. Next slide, please. So the types of spirometry, and there are different types. It is important to recognise the different types depending on the reason for the test. So, for instance, baseline for investigation of general lung function can be used for screening purposes. And baseline, obviously, is also a pre-requirement for reversibility testing. Investigative post-bronchodilator spirometry to support the clinical presentation, such as monitoring disease decline, for instance, in COPD. And reversibility to look for variability of airflow limitation to support the clinical picture. What is important is that spirometry is a tool. The findings from the structured clinical history will determine which tool you choose from your toolbox, such as spirometry, ECG, chest X-ray, etc. Next slide, please. So what does spirometry offer the clinician? The importance of diagnostic spirometry lies in the fact that it is both a test of exclusion and a test of inclusion. It is the recommended objective test performed to identify abnormalities in lung volumes and airflow. It can detect the presence of airflow obstruction, as well as the degree of reversibility achieved with bronchodilator treatment. It can also detect restrictive defects in lung function. There are two elements to diagnostic spirometry: the performance of the actual test and the interpretation of the result, now known as the reporting. Although it may appear to be a fairly simple test to perform, the ability to produce an accurate picture of volumes versus time under forceful effort depends on many factors, both technical and patient-related. Next slide, please. Why is early detection of a lung disease important? NHS England and NHS Improvement in their Spirometry Commissioning Guide identified the following. Earlier detection and diagnosis of lung conditions such as COPD and asthma can lead to early interventions for smoking cessation, optimal treatment, better management of the conditions, and benefits to the health system. Early detection can also lead to a reduction in acute admissions, reduction in non-elective winter admissions, resource utilisation, and improvement in quality of life and health life expectancy. Both under and overdiagnosis of respiratory conditions leads to delayed treatment and increased chance of acute admission. And 10 to 30% of people with COPD are not diagnosed until they are admitted to hospital with exacerbations. We need to identify those undiagnosed patients to ensure they are on the correct management pathway. Next slide, please. The importance of the structured clinical history. Differentiating the different respiratory conditions from each other is critical for an accurate diagnosis and subsequent appropriate management pathway. Respiratory diagnosis is based on a clinical assessment of the patient using a structured approach, and the quality of the structured history is important. It may also direct differential diagnosis. The primary goal is to understand the state of health of the patient to determine an accurate diagnosis. An inaccurate diagnosis can have serious repercussions. For instance, presenting complaint as breathlessness. Until a thorough clinical history is exhausted, followed by inspection and examination, subsequent investigations are not known. Until the clinical history, we do not know whether to do a chest X-ray, ECG, BNP blood test, or spirometry. Next slide, please. So spirometry advantages and challenges. In isolation, spirometry will not result in diagnosis. Spirometry augments the clinical assessment of the patient. It identifies narrowing of the airways, known as obstruction, and reduction in lung volume, known as restriction. Results can be interpreted into normal, obstructive, restrictive, or a mixed pattern. Recognizing the pattern of spirometry after appropriate patient preparation and quality assured performing of spirometry enables the clinician to report the findings in the context of the clinical presentation. Next slide, please. Examples of different spirometry patterns seen in lung conditions. Asthma could be normal or obstructive. Interstitial lung disease, a group of more than 250 pulmonary disorders characterized clinically, the pattern is often restrictive. COPD is post-bronchodilator obstruction, and bronchiectasis population, spirometry when stable airflow obstruction is seen in 41.1%, hyperinflation in 15.7%, and restriction in 8%. This slide illustrates the importance of choosing the correct tool for investigation. For instance, with such a variation in spirometry patterns seen in bronchiectasis, NICE 2023 recommend if bronchiectasis is suspected after the thorough structured clinical history and while waiting for the referral, certain investigations can be done in primary care, such as sputum culture, and investigations in secondary care would be high-resolution CT scanning, which is the most frequently used imaging test to establish the diagnosis of bronchiectasis. Next slide, please. So, use in diagnosis of ILD and IPF. This would be outside of primary care, in secondary care and tertiary centres only. 21 out of 48 had normal FVC/VC, i.e. capacity, not showing any restriction, and it's more likely in male smokers. And there are several other trials with similar findings. The use of spirometry in interstitial lung disease and idiopathic pulmonary fibrosis has some other confounding factors. In a recent article published in the European Respiratory Review online journal in 2018, Planter et al. Found that restriction is often absent at the time of diagnosis. Next slide, please. The ARTP certification. You will need to follow the assessment process set for the type of certification you would like to complete. For example, if you would like to complete the full certification, you will need to successfully pass the portfolio, and this will need to be completed via an online e-portfolio called PebblePad. 20 spirometry test reports, which may or may not be included with clinical information as part of your MCQ timed examination, and a spirometry practical assessment completed virtually. So that's the OSCE, and that comprises of a practical assessment and a viva for the person taking place. Next slide, please. So certificate levels and the assessment. There are 4 types of ARTP spirometry certificates, each with the following assessments. The full, as I said, the assessment is the portfolio, the OSCE and the MCQ. If performing only, the assessment is the portfolio and OSCE. If reporting, you need to complete the full portfolio and the MCQ timed examination. And for those who would like to do a top-up, either from the performing to full or reporting to full, or a top-up from adult to paediatrics, you need to do the assessments, which are portfolio and the MCQ. As you can see, there are different certification levels depending on the requirements for your role. So next slide, please. This slide demonstrates the journey when you apply to the ARTP to go on to the registration. So the registration you can book onto the ARTP website, and that starts your journey on day 1. You then have 9 months to complete all of your ARTP assessments, and it is advised that you start your portfolio as soon as possible. And it is also recommended that you submit your portfolio at month 6, and that allows for any resubmissions, if required, to be completed before the end of your journey, when once passed, you will receive notification and be added to the National Register owned by the ARTP. So next slide, please. Before going any further, I'd like to hand you over to Fiona, who is going to do an online poll.
So it's just to check how many of you have actually recommenced spirometry. Sorry, Julie, you can go ahead.
Okay, so this last slide, recommencing spirometry services. It's important that there is a timely reinstated and identifying the patient population. It needs to align services to population needs, and it needs to determine inclusion and exclusion for patient criteria. And the PCRS have identified that there is, if you like, a priority list for patients who need to perform quality assured spirometry, and those are patients who through the COVID pandemic did not have access to spirometry, so we need confirmation of their lung pattern in order to know that we have the confidence with their spirometry results. It needs to be quality assured, so undertaking a training needs analysis of the workforce, identifying who needs to be involved in the spirometry and what the training needs are for the people either performing or reporting their spirometry. And this enables the providers to create optimal skill mix and capability. And there needs to be infection control policies, so operating risk assessments. So for instance, the ARTP have produced that standard operating procedure, so the SOP, and that will talk you through what's really important in order to start quality assured spirometry, cognizant of the importance of infection prevention control procedures. What has been identified is that recommencing spirometry services across the devolved governments have different priorities. What's really important is that spirometry is reinstated as soon as possible. And the SOP identifies best practice, but it also recognises that working in primary care, there are other restrictions. So the advice would be to contact your infection prevention control services and your local secondary care services, and you will then be able to find out what is the recommendation from the pulmonary functions laboratories in secondary care in order for you to be able to deliver a safe spirometry service for your patients. I'd like to hand you over now to Dr. Steve Holmes.
Julie, thanks so much, and welcome everybody. What a great session we've had so far. Thank you for highlighting things beautifully. I think probably I'm going to come at this quite practically as a co-chair of the Task Force for Lung Health, but also doing some work within NHS England. And I'm cognizant that this is not just an issue for England, it's across the 4 nations. I think the first thing is to be able to really get going with good quality tests. It needs to be funded, be that in primary care, secondary care or the community. And I'm glad to say that NHS England are certainly aware of that, and a lot of our ICBs are too. Great stuff about spirometry needing to be good quality, needing to be safe for us and our patients, but also being done not with them having to wait a long period of time and all the complications of medications being used and mixing up potential results, but in a timely fashion that is close to the patient. I work in a rural environment, not quite as rural as Julie up in Gairloch, but in a fairly rural area where people don't find it easy to travel about a lot. So we've gone to the next slide, please. What I'm going to try to cover is a little bit about fractional exhaled nitric oxide as well, which fits into how in the future we hope to get the diagnosis right. So we've learned so far that spirometry is a good test to help to confirm a diagnosis where clinically it's appropriate in spirometry, in COPD, to help to support a diagnosis in asthma, again with a good history examination. It's not getting away from that. Is less good at helping to diagnose other conditions, but is good for monitoring in some of those conditions. If we go on to the next slide, please, just a quick reminder about the number of guidelines that are around. And if we move to the next slide, please, 3 main ones. The first is the British Thoracic Society Scottish Intercollegiate Guideline Network, which many of us have been familiar with for many years, last updated in 2019, now being combined with NICE and due out at the end of this year, I think probably or very early next year. That really covers the totality of care. It covers all the aspects. We have the NICE guidance, which was very much a partial guide looking at issues to do with prescribing primarily, and to do with diagnosis, but not to do with acute care and some of the special groups. And we have a global strategy which is annually updated, which I think a lot of us take a look at, but doesn't have the robustness of our 2 national guidance, which, as I say, are combining. If we go on to the next slide, please, really important that NICE suggested that we think about having guidelines where we test to make the diagnosis of asthma, knowing how difficult it can be just on history. Perhaps a more robust way of using spirometry and FeNo at the time of diagnosis to inform our diagnostic process would be a good way forward. Andrew Menzies-Gow was the chair of that group, and with his colleague John Alexander published within 2 to 3 weeks in the British Medical Journal saying, don't follow our guidance, please, until you have the testing available. So first point is, if you haven't got readily available FeNo and spirometry, use the BTS sign guidance. When that is available, please move on to use the recommended NICE guidance. If you go to the next slide, the British guidance, the BTS sign, looks at probability-based diagnoses for asthma, looks at high suspicion, variability of symptoms, perhaps evidence of peak flow changes, variability over time, nocturnal symptoms, low peak flows, etc. with a family history might probe us to think about a trial of treatment with a code of suspected asthma. Good response with peak flow or other lung function test along with a validated symptom score equals this is like to be asthma, make the diagnosis, move on. And the initiation of treatment is an inhaled corticosteroid. The intermediate bit is that middle area where we do need to be doing more tests because we're not sure what the diagnosis is. And that's sometimes where I'm a primary care clinician, we might need secondary care colleagues involved. And the last line on that, if it's not asthma, it's not asthma, think of something else. If we move on to the next slide, what has happened over the last couple of years since NICE came out is Andrew changed roles and was for a couple of years the National Clinical Respiratory Director for NHS England and did quite a lot to acquire funding to encourage training for spirometry, and many of you will be aware of this in your patches, both at an ICB and PCN level, that there has been training coming down to most parts of England to allow people to get the time to get that ARTP certification to show that we've got good quality. The other nations are taking independent approaches, but are very much along the same lines. And if we go on to the next slide, please. The other thing that's been going along with that is we've been working towards trying to introduce availability of FeNo, and this is quite variable still in England and parts of the UK, but in some areas now, most of the practices or PCN areas are using fractional exhaled nitric oxide regularly. This slide comes from the British Thoracic Society sign guidance, but is virtually identical to the one that NICE use, showing that the test on its own is not a good test to diagnose asthma, and it's not a good test to exclude asthma. And so key point there, we aren't just having a test and saying, well, that must be asthma. We are putting this into the total clinical and investigative context. Next slide, please. I think that context also has some issues around making sure that clinicians are able to use the results from the spirometry, are able to use the results from FeNo and other investigations, and have enough skills to be able to make a balanced judgment to talk that through and make an appropriate diagnosis. Let me talk about FeNo very quickly for those of you who are not familiar. It's a quick, simple test. Can be used in most children. It probably takes 2 or 3 minutes to undertake, and the results are quickly available numerically on a machine that you can put into your clinical records code, and therefore it's not bad. What else to be able to do about that? It doesn't rely on people using maximal inhalation, maximal expiration and areas like that. It does require users to undergo some training, but that's fairly straightforward and simple, and most can use that comfortably. And I think the other areas along with that are, it does give us a chance to use the test regularly to make diagnoses. What it's measuring is nitric oxide, which is an indicator of eosinophilic inflammation in the lungs. And that again helps to support the diagnosis of asthma. There are some things, like in all tests, that can make the FeNo level slightly higher, the fractional exhaled nitric oxide level higher. Allergic rhinitis, one airway, has the same eosinophilic inflammation in the nose as well as it does in the respiratory passages. That would increase things. Some types of viral infections, including rhinovirus, make it more likely, as do dietary nitrates, which can make the results go up by about 1/5. Taller men, because of a larger lung capacity and larger surface area for which the eosinophilic inflammation is taking place, can have higher results than, for example, children where the level is lower. I think the key thing on FeNo levels being lower are, think about people who smoke. They shouldn't be having lots of alcohol before the test, but caffeine can alter the test and make it lower as well. But probably the most fundamental thing is, if I see somebody with suspected asthma who originally would have had a high fractional exhaled nitric oxide, but I treat them properly with inhaled corticosteroids, or perhaps more as an emergency with oral corticosteroids, the FeNo level will drop down because we've treated that eosinophilic inflammation. Next slide, please. Nationally, what we're talking about is, in people who are not on steroids, a FeNo level of around 40 is thought to be a positive result, and children with lower lung capacities, a level of 35 is thought to be a positive response. But again, it's an indicator, not a diagnosis. And the results on sensitivities and positive predictive values and negative predictive values suggest that 1 in 5 people with a positive test will not have asthma. That's a false positive result. And 1 in 5 people who have a negative FeNo test will have asthma. So that doesn't preclude or exclude clinicians having to make those clinical judgments still. That's going to be part of the challenge as we move forward. Fine. Next slide, please. So this I'm not going to show in any detail, but it's just to let you know that similar to the BTS sign guidance, when you get to the stage of having availability of spirometry and FeNo in a timely fashion, there is another quick algorithm that helps you to run through and what we hope is make a much more robust diagnosis that's published in the NICE guidance. And we should see a merging of those in our total British guidance at the end of the year. Next slide, please. Just wanted to say a quick thing, because one of the other lung function investigations that we do a lot is around peak flow. And one of my key tips on that is to make sure that when people are doing it, they do it properly. They do need to take in the biggest breath they can. They need to blow out as quickly as they possibly can. And they need to do it 3 times, with the best within about 5%. And reset it to 0 each time, keep their fingers out of the way. The straightforward stuff that we know about. The key thing that often concerns me as a jobbing clinician is quite a few patients are coming in with peak flow diaries, and when I ask the patient to demonstrate a peak flow reading, they can't do a peak flow reading reliably. If they can't do a peak flow reading well in the clinical environment with us watching and teaching and coaching them, their diaries are not going to be helpful. So please, again, use that with being circumspect, because high variability in someone who's not doing the test properly is not going to give us any good clinical information on which to base a diagnosis. Next slide, please. So hopefully what I've quickly covered is to suggest that FeNo is a quick, useful test. It does have some funding implications like spirometry, but that has been funded in quite a few parts of the system at the moment, and is increasingly being funded because we know that's important. It can help to identify those who are still having symptoms, who have eosinophilic asthma, and check on their corticosteroid responsiveness. But we do need to be aware of false positive and false negative results. We do need to use these in the clinical context, but it is an exciting development for, I think, the clinicians across the UK when we have this much more available and into routine practice. And I think it will be of great benefit to what the Task Force for Lung Health is all about. And the Task Force for Lung Health is really trying to get a situation. It's a group of professional organisations and charities with patient involvement who are trying to ensure that the experience that we all work for to give better patient outcomes has a much better chance of working with that. So what I think I'm going to do now is hand over to Rachel, who's going to take things on from there. Thank you very much.
Thank you, Steve. If you could have the next slide, please. So to introduce myself, I'm the Diagnosis Policy Lead at the Task Force for Lung Health. And I'm here in that capacity today, but I'm also Senior Policy Officer at Asthma and Lung UK. We are a member of the Task Force for Lung Health, and we provide the Secretariat for the Task Force. And we're here today to tell you about a new report coming out from Asthma and Lung UK, diagnosing the problem, which is due for publication in early August. This new report into the provision of key respiratory diagnostic tests investigates ways to improve early and accurate diagnosis. We're focusing on the key diagnostic tests we've talked about today, so both spirometry and FeNo testing in primary care in England for people of any age with conditions like asthma or COPD. The report is aimed at healthcare professionals and commissioners at an integrated care board level, and it makes the case for the need to ensure timely and accurate diagnosis of respiratory conditions, and why expanding access to these crucial tests should be prioritised despite the difficult financial situation. But it does include clear and accessible examples of how this can be achieved in practice, with a range of transferable best practice case studies. And although we're focusing on England in this report, we know that there are similar issues UK-wide, so we hope this will be useful across the 4 nations. Our report shows that accurate and timely diagnosis of respiratory disease require primary care pathways that ensure prompt access to these diagnostic tests. We are agreeing that early and accurate diagnosis of respiratory conditions should be prioritised, and we hope our case studies will demonstrate how you can do this in practice in a clear and accessible way.
Rachel,
in
sorry.
England and UK-wide. Yes?
Sorry, Rachel, can I just ask you to just switch off your mic and put your mic back on again, if that's okay?
Yeah.
Sorry.
Is that better? How about now?
That's perfect. Thank you.
Thank you, Preeti. We discussed how the establishment of integrated care systems provide greater scope for local planning, and that community diagnostic centres are intended to add capacity, not replace it from primary care, as action is still needed across primary care. So services should not rely on CDCs to meet demand in their area. And we will demand that early and accurate diagnosis for all people with lung conditions to ensure everyone receives the timely diagnosis and the quality care that they deserve. So we're calling for the prioritisation of respiratory health at an integrated care system level, workforce planning and training, funding spirometry, and guidance on the role of CDCs from NHS England. And we hope to see the swift introduction of the breathlessness pathway, which is being piloted now for adults within the next year. And we hope to send you further information about the report after the webinar. Thank you very much.
Thank you, Rachel, for that. I think there may have been some sound, which we will resolve and send out a follow-up around the report. So we'll send that all to all delegates. So thank you all so much for your questions. If I could invite Julie Lennon and Dr. Steve Holmes back. We have a couple of questions. So it's really great to see. So thank you all for your participation. So if we start with a couple of questions around FeNo. So let's start with for a suspected asthma diagnosis, if the baseline spirometry is normal, do we still need to perform reversibility to check if FEV1 improvement? Sorry, that should have been in the spirometry, but if we can answer that, that'd be great.
Okay, thank you very much for that question. And it's actually not quite as clearly structured as the question might suggest, because you might think with normal spirometry there's no point making any changes, but the spirometry values are classified against predicted values. And some patients have much greater capacity than predicted, have a much better FEV1, forced expired volume in that first second than predicted. The short answer is you might want to consider something else, such as a peak flow diary for 2 weeks. I personally have on more than one occasion done reversibility on what appeared to be parameters that were within the normal values. However, having done reversibility, the lung function of the FEV1 improves by 200 mils or more, which also represents 12%. So you really have to look at the clinical history and what that presentation was there for, because it is the tool. And maybe, Steve, if you wanted to add to the value of maybe looking at FeNo to support that if we've got a negative, a normal spirometry result.
I think you're right, Julie. Probably one of the key things I would say is asthma is a variable condition. If you think about a lot of patients you see with something like eczema, it's not bad all the time. It comes and goes, it varies. And if you catch somebody with eczema when things are good, you won't see much evidence of their eczema. When it's bad, you'll notice it very clearly. Exactly the same with people with asthma and actually a lot of other medical type conditions. So the history and their symptomatology at the time is very important. Equally so, we're going for normal results, not personal results. And obviously some of us are taller, some of us are smaller than others. The same with weight. There's a range for the whole lot of us, but what we don't know when we're doing that spirometry to begin with is what was normal for them. And so I would be veering towards Julie. If I'm thinking this is genuinely asthma, I would probably be doing reversibility testing on that patient as a standard rather than just baseline spirometry.
Great, thank you very much. So let's move on to the next question. So I'll just move on to a combination of spirometry and FeNo. Is we do not have access to spirometry or FeNo in primary care for paediatrics. What do you suggest to diagnose asthma in this cohort as unrealistic to refer all children and young people to secondary care for spirometry and reversibility, or peak flow variability, or trial of ICSs? So what do you suggest for this group of patients?
Okay, I think that's a really good point. Do you mind if I answer part of that, Julie, then you chip in? Number one, we should not discriminate against children, and children require just as much of a robust diagnosis as adults. And if we're lagging a bit behind in children, we need to catch up. That's really essential and important. And in primary care, we actually manage both children and adults in the same situation. And there's a bit of catch up going on at the moment with ARTP, recognising this and recognising that a lot of people will need to be dual trained to be managing both of those in that primary care setting. I would be averse to trying to just send everything to the hospitals because they're not funded to do this either, in the same way that quite a lot of our places aren't. What we need is the system to fund appropriately so that it can be done. If you don't have someone who can do paediatric spirometry, somewhere where it can be that's close, timely and good quality. So that's the key bundle there. I would go back to the presentation I gave when I mentioned about the NICE guidance. If you don't have the tests available, rely on the British guidelines, the BTS sign guidance, which is about probability. If there's a family history, if there are symptoms, if there's symptoms occurring at night, better in the morning, you're getting evidence of reversibility on their peak flows in the practice, which you can do very quickly. And you've also got symptoms of listening into the chest when they're symptomatic, detecting an expiratory wheeze, then you're thinking high probability asthma, let's try treatment, let's give them an inhaled corticosteroid for a period of time, expect good improvement, expect their symptoms settle down, expect they're back at school. Does that sort of make sense? Julie, do you want to add anything?
No, actually, Steve, I think you've covered it all. I couldn't agree more. And it is about the probability. And I often say it takes several consultations sometimes before you've got that diagnosis of asthma, or before you've ruled out other things that it can be. Always have on your radar, you know, to think, rule in and rule out. What else could it be before you consider that this is suspected asthma and treat accordingly? But absolutely, the probability, I think it's really clear and easy. It's very, very easy to navigate, very easy to negotiate with parents and carers, and like you said, Steve, get the children back to school so that they don't even know they've got asthma because they're so well treated.
Perfect. So thank you both. So I guess while we're talking about both spirometry and FeNo, what would you both suggest is a timely manner between delivering spirometry and FeNo for a patient?
It's better if I can just start with FeNo. With all tests, actually, it's always better to start before treatment has started, because once you've started, for instance, inhaled corticosteroids, it's and I'll let Steve answer that in more detail, but it's more difficult to get that full objective assessment. Certainly where I work here in the surgery, we have such easy access to spirometry. It's as easy to do as a peak flow, and it's always on the basis of that clinical presentation. And as I said in my presentation, until you've taken that structured history, for instance, let's take breathlessness in an older person, until you've taken that full structured history, you don't really know what tool to take out of your toolbox. So I would do the tools as soon as possible, the tests as soon as possible, but also, as the guidelines say, we're not going to not treat the patient whilst we're waiting for those tests or access to the test. I touched on devolved governments and their approach to reinstating spirometry, and England, Scotland, Wales and Northern Ireland have all put statements forward and mission statements forward about we really do need to get this up and going as soon as possible. So if you look at anywhere your devolved governments, they really have got a strong opinion that we really need to reinstate spirometry, but we're not going to not treat a patient because we haven't got access to spirometry for a month or sometimes up to a year.
And I guess probably what I think on that is exactly what Julie said. Two things. One is we're getting a better idea of the numbers of spirometries and FeNo tests that are required to make those sort of diagnoses. Remember that every test won't always be positive. I think the other key thing we've reiterated a few times is the importance of making sure that we've got a good assessment to judge on that. And probably the last thing I would say is restrictive problems. Don't just do spirometry because you think, well, I'll just do it anyway. If you've got a restrictive problem, something like a pleural effusion, interstitial lung disease, lung cancer, by the time it becomes restrictive, the disease is very advanced. For that, you need to have a good clinical history, you need to think about appropriate imaging, and you need to think about other conditions that are going to come into it. So please use the test appropriately rather than saying, well, I can send them off for a couple of weeks if I do a test, but it probably won't help me either way.
Thank you both. So just concentrating on FeNo specifically, so we've got a question here around if you're suspecting asthma and wanting to do FeNo, but already started on ICS, would you stop the ICS for a certain time in order to perform FeNo?
Yeah, very quick answer to that. It's a bit like the same question comes up with spirometry as well. Do I stop the treatment beforehand? And that really, again, depends on the severity of disease. There's no specific guidance that says 1, 2 or 3 weeks stop and then it'll be fine. Somebody with very brittle disease, if you stop their inhaled corticosteroids, will have symptoms quickly. They might even end up in hospital whilst they're waiting to get the test done. So think that one through carefully. If they've got very mild disease and actually just keeping a low dose ICS going in, you might have to stop it for several months before they get more variable symptoms again. So it's not a straightforward answer of stop it for 2 weeks and the result will be reliable. If they have symptoms and you're doing a FeNo test and those symptoms are persisting, when they come back, what you're looking for is to say, does that person have evidence of eosinophilic inflammation linked to those symptoms, or is the symptom due to something else? Is it due to deconditioning? They're not very fit. They've been isolating for a while with COVID. Is it because of their weight that's making them more breathless? Is it something like a breathing pattern disorder? Again, always think widely and clinically. These tests are here to help us, but not to specifically make it as easy as anything.
And I think that really demonstrates, isn't it, about taking a person-centered approach in your consultations as well. So again, going back to the diagnostic test, give you a bit of a picture, but it's that clinical history taking which is really important. So just staying with FeNo for a little bit is why do FeNo values change every time in tests? So I know we talked a little bit, I think you alluded to this earlier on in your presentation, but if we can just get some clarity on that. Okay,
but very quickly, like a lot of things in life, like weight, like our blood sugars, like our sodiums, potassiums, there's always a degree of variation going on. One of the things is we eat variable amounts of vegetables every day. That will influence the amount of nitric oxide we're doing. If we smoke, that's going to have an impact, as we put down on that one of those slides. And probably one of the key things is if somebody who has asthma is complying with treatment, their levels will drop down usually. If they're not complying with treatment, it will go up. So there is a lot of natural variables, cough, cold, viruses, as well as treatment variables that can influence that. And that's where, again, you use the test to help to inform your decision making with the patient, not to just say the test says this, therefore I must do that.
Perfect. So we talked a little bit around the guidelines earlier on, and also in this Q&A session. What are your thoughts around the 2023 BTS sign? Do you think it'll include the FeNo? And if so, which guidelines should we use, whether it should be BTS sign or NICE? And I think you've covered that already. And should FeNo be used in suspected bronchiectasis?
Right. Do you want to answer that one, Julie, or shall I have a quick crack?
Yeah, you carry on.
Okay, number one, FeNo is recommended in the BTS sign guidance, and it's recommended in the NICE guidance. So no change. I can see FeNo still being recommended as a useful test using the sort of parameters we've talked about today. That's quite hard to put into writing in a guideline, but hopefully what you've got the idea of, it's a variable condition. There's quite a lot of other complexities in how we do that. But FeNo, I think, is here to stay. It's been in the BTS sign guidance for about 5 years. It's been in the NICE guidance as well. So no change there. Sorry, what was the other part of the question?
Should it be used in suspected bronchiectasis?
Not particularly, unless they, if they've got asthma with bronchiectasis, you might be using it there. But like COPD at the moment, the jury is very much out on other tests. There are trials going on, but I wouldn't be starting to do that in any form of routine way. And I wouldn't be using it to inform a diagnosis of bronchiectasis in the same way I wouldn't use spirometry. If I was thinking about bronchiectasis, I'd be looking at a high resolution CT scan.
And if I can just add to that, Steve, as well, in regard to bronchiectasis, absolutely, it's refer secondary care for high resolution CT. Just occasionally, you might want to do spirometry with somebody with bronchiectasis, but that would be to exclude coexisting COPD rather than any supporting of diagnosis for bronchiectasis. So that would be purely looking at comorbidity.
And one other interesting point, and I noticed, Julie, you said refer to secondary care for a CT scan. About a third of people I speak to nowadays actually have direct access in primary care to CT scans, and it has been recommended that all do. So, and there are people in Scotland that do, but there are areas that not the same as in England. Again, probably what we need to be doing is making sure clinicians are trained to be able to request those sort of tests when it's appropriate and put the right details in, so our radiologists say they know what they're doing. That test will help to inform their clinical practice.
And I think that just demonstrates, isn't there, there's still that regional variability in health, particularly access to tests. So it's something that, us all getting off on the same page will help to try and reduce that gap. Just sticking the last kind of couple of questions around FeNo is, how long would you suggest someone avoid smoking before FeNo? So before undertaking FeNo, I guess.
Or about 70 years. What we want is people to stop smoking, so we need to be giving them very brief advice that the best way to stop is through effective professional support and some of the medications we've got available. I'm trying to convince people to stop, not just to stop for a few days. Yeah.
Julia, is there anything you'd like to add on that?
No, I couldn't agree more. Any opportunity or situation where you can negotiate with the patient to consider stopping smoking is really important. And I've had some success with patients when they look at their spirometry and looking at the trajectory, but other patients are just not at that right stage to stop smoking. But as you said, Steve, it's that very brief advice, 30 seconds in every consultation, if you can, about just checking smoking status, just to sort of reiterate the importance of smoking cessation.
Perfect, thank you. So we've got a couple of minutes remaining. So I'm just going to jump onto some spirometry questions. So post spirometry, can we still use Ventolin inhalers, or which inhalers should we use, please?
Is this for post bronchodilator spirometry? Is that the question?
The individual hasn't specified, but if we take it for that, that would be great.
Okay, yeah. The general protocol for post bronchodilator spirometry is 4 puffs of salbutamol via a spacer. And we would do post bronchodilator spirometry if we were considering that the patient was presenting with COPD, and we're looking at their lung pattern and airflow limitation, and obviously the obstructive pattern in that airflow limitation. Different guidelines say different things, but generally speaking, and in fact, I did a search for the different guidelines for the use of salbutamol or Ventolin as part of reversibility, and they are now on the ARTP website. But generally speaking, it's 4 puffs of salbutamol via spacer, waiting at least 15 minutes, preferably 20, because that gives you that more security, but at least 15 minutes, and then you'll do the spirometry. And don't forget to do the relaxed blow as well, because you'll be looking for things like air trapping.
So this one's a little bit of a wider question to you both. Is we are currently living with COVID-19, but we stopped doing spirometry because it was an aerosol generating procedure. Now that we are catching up with spirometry, what work has been done on the demographics, comorbidities of the clinicians who previously performed this pre-COVID without PPE? And has there been any occupational risk analysis and evidence-based research into what is appropriate PPE for performing spirometry?
If I could just say that spirometry is not an AGP, aerosol generator procedure. That has been confirmed in many documentations, but cough-induced spirometry has the potential to be an AGP. Initially, there were recommendations about appropriate PPE, such as masks, apron, visors in the to be worn, fallow period between patients. So at the end of the day, 6 air changes per hour. And so it goes on and on. And in primary care, which is where I'm based, we really had difficulties trying to recognise how on earth we could monitor and demonstrate 6 air changes. I've asked around people in England, Scotland and Northern Ireland. My advice would be that you contact your local infection prevention and control team and your local pulmonary function laboratory to find out what their recommendations are. Anecdotally, most people now are moving away from full PPE. The important thing is having good ventilation in the room, good air circulation, assessing the patient, so making sure you do that pre-check list quite apart from everything else, so the relative and absolute contraindications, but also looking at from a respiratory perspective as well, to make sure that they're not presenting with any respiratory presentations. Some in Scotland we have health boards. Some health boards ask for a lateral flow test before the procedure. Other health boards aren't asking for that. Some health boards have perspex screens, other health boards don't. So I think contact your local IPC team and your local pulmonary function test unit to find out what their recommendations are. And don't forget the standard operating procedure, the SOP, that was published this year by the ARTP. That gives you some guidance and some recommendations. Steve, would you like to add to that?
The only thing I'd say is at a strategic level, looking, and I've been in our practice, we've been doing spirometry for the last 18 months, but some of the practices, my ICB, still haven't plucked up the courage yet. One of the things I reflect back on is it's probably sensible to get a couple of influencing practice nurses across the patch, a couple of physiologists and infection control around the table in whatever health board or community system you've got, to agree on the sort of parameters that you're using in your locality, depending on the risks and what else is going on.
Perfect. Well, thank you so much to you both for your sessions and answering the questions and putting you on the spot. Next slide, please, Fiona. So that has brought us to the end of this webinar. We will be doing another webinar in collaboration with Task Force for Lung Health in the autumn, and we will be releasing those dates shortly. As Rachel mentioned, there will be reports coming out, and again, we will be circulating that to all of you. So just a moment to say thank you to all of our guest speakers today. Thank you for attending this webinar. I know there are a couple of questions that we unfortunately didn't get to because of time, but we will make sure that we will put out some guidance for that, and we've got all of your email addresses, etc. So we will be sending you out a follow-up. And really just shows by working together, we can really improve the lives of those living with respiratory conditions. So if you'd like any further information around our spirometry programs, then please do visit our website, which is www.educationforhealth.org. Alternatively, if you have any questions around the policy or the report that Rachel mentioned earlier today, you can see the email address on your screen there. And just to finish off, really, you'll see that a little poll has come up on your screen as to whether this webinar supported you to expand your knowledge in spirometry and FeNo. And if you could click on the stars, that would be great. And that gives us some real information in terms of how we can support you further. Again, thank you for attending today, and I'd like to take a moment to say thank you to our sponsor as well, NewMed Healthcare, and thank you once again to our guest speakers. Bye-bye.